Hi guys, welcome to week 3 of your nursing education. Today we're going to talk about medication administration. This is one of the key components of your nursing tasks that you'll do. You'll do medication administration whether you're in an outpatient setting, an inpatient setting, long-term care. It's one of those types of activities that you'll do that carries risk. So understanding medication administration and taking it seriously is a key component to your success as a nurse. So some terms we're going to get started with is we want to know what a drug is. And basically a drug is going to either affect the person's physiological function either in a positive or negative way. We're going to look at a medication, and we term a medication to be a drug that we give because we want to achieve a therapeutic effect. We want to lower somebody's blood pressure. We want to increase somebody's blood pressure. And so we give a specific drug to create a specific effect on this physiologic function. And when you look at drugs, one particular drug can have 4 separate designations, but it's the same drug. It can have a chemical name, which is its chemical compound. It can have an official name. It can have a generic name. It can have a trade or brand name. And so during your education, we're going to teach you mainly the generic names of medications because that is how you're tested when you go for your licensure. And so you'll hear us talk about what is the generic name. We look at medications. Even the same medication can vary in purity, potency, efficacy, safety, and toxicity with patients. And so those are highly regulated, so that if you have a specific generic name such as ibuprofen, that makers such as my brain just went blank, Advil and Motrin, and the generic of ibuprofen that you see have the same purity and potency so that they can be considered equal in their efficacy. So we also have controlled substances. These are medications that are labeled to have a high degree of abuse or addiction properties within them. There are 5 particular categories in which controlled substances are categorized in. And if you refer to the table 35.2, it will show you that. As nurses, we keep very accurate records. Pharmacists do, manufacturers do, and those who dispense as well. You need to know that if you're only going to give a partial dose, the unused drug is actually wasted in a specific manner. Most places require 2 licensed personnel to watch the waste and sign for the waste. Where exactly you're going to place that waste and how is specific for each drug, and often those policies that you see at the hospital are driven by the DEA because they're the drug enforcement agency that regulates and enforces our compliance. So there are medication regulations. They can be regulated at the federal level, the state level, and the local level. Also, healthcare facilities can develop specific policies and procedures. However, those procedures must comply with the federal regulations, state regulations, and local regulations. Oftentimes, they could be more restrictive than the prior ones I just talked about. Functions and professional responsibilities of nurses are defined by our state's Nurse Practice Act in terms of how we are able to manage medications for patients. So it's important to understand your own specific state's Nurse Practice Act so that you practice within the regulations of that. What is our responsibility? Our responsibility is to understand and follow our Nurse Practice Act, the policies of the facility when administering any medication, and paying close attention to controlled substances. So there are a couple principles of drug actions that you need to be aware of. One is pharmacokinetics. That's the process in which the medication is entered into the body, how it moves through the particular body systems, and ultimately how it leaves the body. And you need to know about pharmacodynamics, which is the process of how the medication actually interacts at the cellular level to initiate the response physiologically that we are desiring. And that response can be both positive and negative. So we also need to know about the therapeutic effect. So the therapeutic effect is what we want the action of the medication to be. Medications must be prescribed. The therapeutic effect is related to the route, frequency, and dosage. Therapeutic effect, whether we can achieve it, can also be enhanced or inhibited by pre-existing conditions or current disease processes going on. And other medications can impact the ability to reach a therapeutic effect. So medication actions are also dependent upon absorption, distribution, and metabolism, as well as excretion. So what is absorption? So that is the passage of the drug from the administration site into the bloodstream. So how does it get there? Are we giving it orally, where it is absorbed in the gastrointestinal tract and goes through what we call first pass metabolism, and then it goes to the liver before it reaches the bloodstream? Are we giving it intravenously, where we're administering it directly into the bloodstream? So there's a distribution. How is the medication delivered to the tissues, organs, or a specific site of action? Are we taking the medication directly to the site? Are we looking at how the tissues and organs are perfused and relying on our blood flow to distribute the medication to where we want it to go? Then we look at metabolism, is how the drug is altered to a less active state as it begins to be prepared for excretion. And we also look at excretion. This is how it actually leaves the body, and it can be through urine, it can be through feces. So we have to look at where is the drug actually excreted. We look at pharmacodynamics. We look at the biochemical responses to drugs. Can either be systemic or it can be local. And we look at that and we evaluate how there are changes to the patient's clinical condition. This is where we look to see if we're getting that therapeutic effect that we're desiring from actually initially prescribing or administering the medication. We often look at a medication's half-life. A half-life is the time it takes for the blood concentration of the medication to reach half of the original dosage. And this varies for various medications. And this comes into play if you think about it. If I have a medication that has a long half-life, such as a benzodiazepine, and I want to give one, do I want to give a benzodiazepine that has a long half-life, which means that when I don't give another dose, it's going to take longer for that dose to actually metabolize and get out of the body? Or do I want one that has a short half-life, so that the patient may start to come back to normal central nervous system responses much quicker? We look at the onset of action. Okay, so how long is it going to take from the time I administer that drug for it to reach, to start its beginning to create its therapeutic effect on the body? And we pay close attention to onset of action when we look at insulin administration, because when you talk about insulins in your pharmacology class, you will talk about there are rapid acting, short acting, intermediate acting, and long acting. And each of those has a different onset of action. And understanding the onset of action can help us prevent that patient from developing a low blood sugar or hypoglycemic reaction. For some drugs, we want to look at their peak plasma levels, and this shows us when the drug has the highest concentration within the blood. And then we also look at what's called a trough, or a trough plasma level, which is the level that is the lowest in serum level of the medication. You'll see this sometimes with medications such as vancomycin and gentamicin. They're antibiotics. And the reason we look at peak and trough is that we want to make sure when we believe the medication should be at its highest level, is it within a therapeutic range? And when it is at its lowest level, is it at this range that we want it at its serum lowest level? And we look at that for two reasons. One is to make sure that the patient is getting adequate antibiotic coverage, and also these medications have a high level of toxicity that can develop. So if we're getting a higher than we want serum blood concentration with this peak level, and additionally at this trough level, the doctor is going to want to modify the dosage or perhaps the frequency in which the patient receives that medication, or both of those. So we want to look at side effects. So side effects are those unwanted or unavoidable reactions to medications, such as nausea, vomiting, perhaps headache. Then we have adverse reactions. Those are more serious, however unintended and unwanted. They're unpredictable. So they happen, but we can't predict that they're going to happen. And they could happen, but they're just more serious, such as with Levaquin. Let's just say Levaquin, which is another antibiotic. Patients can develop pain in their calf. And one of those adverse or severe unintended responses the patient get is that they can actually develop a tendon rupture. So we tell the patients to watch for pain in their calves that wasn't there before they started the medication, or perhaps the result of an injury. We also look for toxic effects. This means that the patient has had either an intentional overdose, or there has been buildup of the medication in the bloodstream because they have an impairment in their metabolism or the excretion process. Patients can also have allergic reactions, and these are unpredictable initially, and they involve the immune response to the medication. And allergic reactions develop over time. So you have to have an initial exposure to the medication in order to develop this immune response to the next time you receive the medication. You can have a minor allergic reaction, such as skin rash, swelling, or hives, or perhaps it may be more severe, such as an anaphylactic reaction. And anaphylaxis is a medical emergency. So treatment, we discontinue the use of the medication. We provide any type of symptom management for someone with a minor skin rash. We perhaps might give them Benadryl. We might apply some hydrocortisone cream to the hives on the skin for the itching. Patients with anaphylactic, we generally use epinephrine, and we might give them IV fluids. Sometimes patients will get steroids, and in very severe cases, they're going to require some respiratory support. We encourage all patients who know they have an allergic response, they need to carry some type of communication record. So if they're found in the public unresponsive, the people who treat them are aware of these allergic reactions. And we do know that we try to state all allergic reactions, allergies or allergic responses on the patient care record when patients are in the hospital. So patients can have non-prescription medications. These are generally over-the-counter medications, and they're able to be obtained without a prescription. We want to be sure that when patients are doing over-the-counter medications, that they understand what the desired effect they're wanting to achieve, and that they have the right over-the-counter medication to get that effect. They should understand and read that whether there are side effects or adverse effects to the ingredients, just like some people with blood pressure can't take certain cold remedies. And that they need to understand they can develop an allergic reaction to over-the-counter medications, that there could be interactions with other over-the-counter medications, prescribed medications, or herbs. And they need to understand the dosages and how they need to take it, what the maximum amount of dosage they should take in a 24-hour period, and what they should seek medical help for if they continue to take it and seek no relief. And if you read some labels on non-prescription or over-the-counter medications, they're beginning to do a much better job about informing the public on the boxes about those particular points. Many patients will also take herbal supplements or vitamins because they want to support or maintain their health. We need to be aware that there's also limited regulations on the purity or the potency of these herbal supplements, so they may not always have the same potency from manufacturer to manufacturer or batch to batch. The FDA is attempting to regulate some of the herbs and dietary supplements and educate people about this. And we need to understand that many herbs can have similar properties to prescription medications. And so patients need to be aware and be discussing whether they're taking herbs, because they can impact how the medications they're taking that are prescribed are being absorbed or metabolized within their body, which can have an impact on therapeutic effect or the development of toxicity. So we have prescription medications. Prescription medications can only be prescribed by people who are licensed to prescribe. And if I were to prescribe, or you were to receive a prescription for a patient, say at discharge, and you're reading it, you need to make sure that it contains the following information. It should always have the patient's name, the date. Sometimes you'll see the time that the prescription was written, the name of the drug, the dosage, the route, the frequency that the patient is to take the drug, and the signature of the person who wrote it. If any one of these are missing, it is not a valid prescription. So when we look at the Medication Administration Record, or MAR, or you may hear people refer to the EMAR, and EMAR only means that it's done electronically. That stands for Electronic Medication Administration Record. So these can be used in inpatient and outpatients. So what should they have? The patient's full name and date of birth, the full name of the medication. We look at administration time, dose, route, and frequency, the site of administration. So if it's, we need to know not that it's a parenteral medication, which we'll talk a little bit about later, but whether or not that's going to be subcutaneous, is that going to be intramuscular, or is that going to be IV? And we want the nurse's initials and signatures, and we put the prescribing healthcare provider on there. And what the MAR shows us is previous doses that were administered, who did, and the time, which is what the T stands for, and I apologize, of the medication. And we need, but there is specific documentation that each facility has when a medication is not administered. It could be not administered because the patient refused it, because we held it, because there was a patient assessment data that we felt that the medication needed to be held. The patient may be off the unit at the time. The patient might be in surgery. There are multiple reasons why we might hold a medication, but we do need to document that, and that is generally policy specific to facility. So what is the nurse's role? So we need to know why the medication is ordered. We need to know what the medication is. So that means we need to know its classification. We need to know what its side effects are. We need to know what its intended effect is to be on the body. We need to know if the patient has any contraindications or reasons he should not get it. Are there any parameters in which we would hold it? And are there side effects or monitoring parameters we're going to look at afterwards? So we need to know why the patient is receiving it. We need to know if what we see on the medication order is within the dosage range limits. Often, sometimes you could get a medication ordered with a dosage that is outside the normal, and that is pause for you to question that order. Okay? We want to make sure that the frequency and the route are within normal limits. Okay, can this medication really be given IV? Was that just a transcription error? Did the physician, when he was scrolling down, hit the wrong one? Because there are medications that cannot be given IV. There are medications that cannot be put down an NG tube and be crushed. So we need to pay close attention to those things. We need to be aware that medication orders can change based on the status of the patient. So what we think the patient will get when we first check that medication administration when we come on shift, by the time we go to administer those medications, our medication administration record could have been altered. So that's why we always are vigilant in staying current on what the new orders are. And often in some facilities, medications need to be reordered. After a patient goes to surgery, or they're reordered on discharge. And in some facilities, they might even need to be reordered on transfer from one unit to the other. Say the patient is being transferred from the ICU to the medical floor. Medications are reordered for the patient arriving to the new nursing care unit. So medication forms and routes of administration. Okay. So nurses must administer the correct form of the medication. And what I mean by form is not like a written form, but the form in which medications can come in. They can come in tablets, capsules, liquids for injection, those types of things. So we need to be sure we're giving the right form of the medication and the right route, because we want to achieve really the optimal effectiveness and for patient safety. So there are routes of medication administration, and medication preparations are not interchangeable for alternate routes often. So I can't give a tablet IM, and sometimes I cannot give how I've mixed this medication in an IV as I've mixed it to give IM. So we need to be sure that we have done it correctly. If we're giving an IM, we've prepared it for the IM route. Some common routes of administration include oral, buccal, sublingual, parenteral, topical, by inhalation, and perhaps through a medical tube. Each route has its positives and negatives. So oral administration, we're going to talk about first. The most common medication route is oral. You'll see it on the medication administration as PO, which means per osseous. And so we often consider it to be the safest. It's generally the most convenient. And for the patient, it is the least expensive method. So as a nurse, what are you responsible for? Ensuring that all medications taken by the oral route are actually swallowed by the patients. Patients sometimes won't completely swallow their pills, or they'll be dissolving in their mouth. They'll spit them out. They'll put them under their tongue because they don't really want to take them. And then they'll just, when you leave the room, they throw them away. So we want to be sure that the patient has swallowed the medication. So we need to know also that it's a slower onset of action than if I gave the same medication, either IM or IV. Some of the nurse's responsibility is that we have to be sure our patients are able to swallow, not only swallow water, liquids, but that they have the ability to swallow the size of the pill. Some pills come very large and they may need to either be crushed or they may need to be broken in half to allow for ease of swallowing. Oral forms of medications can be tablets, capsules, or liquids. And oral medications are often given via NG tube, a gastric tube, an intestinal tube, or a jejunal tube for patients who aren't able to swallow. We can also give patients sublingual medication. This means that the tablet is placed under the tongue and that tablet will dissolve. So the medication is absorbed through the oral mucosa. And sometimes we do this because it can prevent some gastrointestinal injury. We also do it because we might get a little bit quicker response from a medication. We might do it, say we can give a medication called Zofran, which is what we call an antiemetic, which is an anti-nausea pill. So if my patient is vomiting and unable to keep anything down in their stomach, I can give them a sublingual, what we call ODT, under the tongue. Oral dissolving tablet is what ODT stands for. And they can get some relief from that nausea without having to take a tablet. We can put it in a buccal, which we put it against the mucous membrane in the cheek until it's dissolved. So we can use topical medications. These are medications that are applied to the skin surface or a mucous membrane. They can come in liquids, ointments, lotions, or sprays. They can be on any membrane or skin surface. The absorption time is often affected by the vascularity or the vascular supply to that particular site. Sometimes they require additional applications. Transdermal patches are another form of topical medications. And these are medications that are in a patch form, and the medication is absorbed over time at a specific dosage. Regardless of the type of topical medication, as a nurse, you should always use gloves when you're using topical medications to prevent absorption into your own skin. A caveat for transdermal patches that you need to be aware of as a nurse is when you're changing transdermal patches, a couple of the things you need to do, please write this in your notes, is you will rotate sites. You will not rub the top of the patch where the medication is, because that will increase absorption at that moment. You won't rub the area after you've removed the patch where the previous patch was. You need to be aware that there are medications still in the patch when you remove it. It's usually not completely absorbed. Those patches need to be disposed of per policy of the facility you are at. And when you put the patch on, you need to date it and put your initials. And within the documentation, you need to document the site you placed your patch on. And we don't put patches over bony prominences because we don't get tissue absorption that way. So you may have to use nasal drops. And this is just a schematic about how you would put the drop in the nose. You can either tilt the head back and drop it in, or you can tilt the head to the side. And this is the sinus area that they would get it. Try not to stick the dropper into the nasal cavity very far. You put it at the base of the nasal cavity, and you try to go give the administered amount. You leave the patient laying flat for a little while, because if you sit them up, the medication will run out, and then we will not get any effect of the medication. I don't see many nasal drops used. I see nasal sprays where the person, such as Flonase, will put the sprayer in and do a spray into the nose and sniff the medication in. You will be putting eye drops or perhaps eye ointment in the eye. So some of the things you want to remember is that you're going to avoid the cornea. You're going to avoid the eyelids. and because that can increase infection, especially if you touch with the dropper or the end of the ointment tube. And we never share eye medications with another patient. So often what we do is, as you can see, that sometimes you want to do intraocular, where you're actually going to and we'll go over this when we have a lab and do demonstration, but what I want to talk about right now is the picture. So as you can see, the person is putting a drop in the eye. We pull the lower lid down so we can see the inner portion of that lid, and that's where we want to put that drop. So we're going to allow the dropper to form a drop. We don't want to squeeze it because we can't control the amount in the drop. So it will form a drop once we hold the bottle upside down, and it will drop in. Once it drops in, we release the eyelid and ask the patient to close their eyes and kind of move their eye inside their eye to spread that medication. And we always provide the patient with a tissue, because when they reopen their eye, it may be a little watery. When we're applying ointment, we use the same procedure, and we just draw a simple, easy line in that same area of ointment. Often you may have to put ear medications in. We often put ear medications more in children than we do in adults. But the installation is we are going to pull the outer area of the ear back and slightly up. What that does is it straightens the ear canal for us. We need to be aware that these structures are very sensitive to temperature, and so we want to be sure that we're not using cold or refrigerated solutions or overly hot or warm solutions. Usually we use solutions that are at room temperature. The solutions are sterile, so as you can see, we don't want to touch the tip of the dropper to the ear tissue at all, because we want to prevent infection. The patient may be sensitive if they have swimmer's ear, and the infection we're treating is in the outer ear canal. So we want to be very gentle when we do this. Sometimes we'll put a cotton ball just slightly inside that ear canal to keep the medication in, but we do want the patient to be flat and on the side in opposite of the ear. We're going to put the drops in, and we'd like them to lay there for, I would say, about 10 to 15 minutes to make sure that the fluid has gone down the ear canal. And sometimes if you reach behind your ear and you do a little pumping action, you can actually help the flow of the medication down the ear canal. We need to be aware that if we see any type of drainage, whether it's yellow or bloody, you could have a rupture of the eardrum. And we're not going to force the medication into the ear canal. You may have to give a vaginal medication. We encourage patients to empty their bladder. It makes it a little more comfortable inserting it. We have them lie on their back with their knees flexed up, similar to when women get a pap smear or a pelvic exam. If they can't tolerate that position, they can certainly lie on their side, but we ask them to bend their knee. We want to be sure we have well lubricated the tip of whatever the medication insertion device is. We want to make sure that the outer structure of the labia, that area, has been cleaned. So we're going to do some pericare before, and we're going to fully insert that medication into the vagina. And it could be a cream, it could be a foam, it could be a gel, suppository, or a douche type medication. Patients receive rectal medications, so it's going to, we encourage the patient to lay on their left side. We want to be sure we fully lubricate the medication. We're going to, on the suppository, insert the rounded part. And I encourage people to use their longest finger. That may not be your middle finger. Look and see what is your longest finger. That will be the finger you'll use to insert it. We're going to gently push along the rectal wall to avoid the suppository going into the matter that is in the bowel. And the patient should try to lie either in the side lying position or position of comfort for 5 to 10 minutes before, longer if possible, before they try to have a bowel movement, because the suppository could immediately fall back out. The patient may also get an enema this way, and we use the same procedure. Patients could have inhaled medications. These could be metered dose inhalers. They could be nebulizers. These are medications that are taken through the respiratory tract, so the patient is breathing in the medication. So in order to receive the medication, the patient must be at expiration, so the lung is as fully expanded as it will get. And we'll have some demonstration of this in the hour that we're in lab, and you'll get to practice. Parenteral. So this is medication administered through a needle. So it's going to go into a tissue, a muscle, or a vein. Absorption is usually faster and more complete. Of the choices of parenteral routes, IV is the fastest. We need to be sure that we use aseptic technique because we've disrupted the protective barrier of the patient, which is the skin, in using these routes. There is also a risk of damage to tissues, muscle, or blood vessels. You can receive parenteral injections either intradermal, which the abbreviation is ID, and this is placed just under the dermal layer of the epidermis. It could be subcutaneous or SubQ, as you will see it written on an MAR, and this is into the subcutaneous layer of the skin. It could be intramuscular or IM. So we're going to inject into the muscle, and we want to be sure that there is adequate muscle in relationship to the type of medication we're giving and the amount. And there's intravenous, which is injection directly into the vein. We're going to talk more about this, but this is a good chart for you to just kind of review and keep in mind, because some of the things decisions you're going to make as a nurse is syringe selection, needle size, and site based on the route of medication you're going to give. So we know that we use syringes, and they're generally plastic. They contain a barrel, a plunger, and a tip. We can touch the outside of the barrel and the plunger handle, and generally there are standard syringes, tuberculin syringes, and insulin syringes. So these are an example of these. The upper two are just standard 3 milliliter, 5 milliliter syringes. Number C that you see, it would be a TB syringe, and the lower one is a insulin syringe. And you notice the top two are in milliliters. The next one is in milliliters as well, but it's broken down into tenths of milliliters for intradermal because we give such a small amount of volume. And D is your insulin syringe, which is labeled in terms of units of insulin and not milliliters. So that's why you will have to choose the appropriate syringe for the appropriate parenteral medication administration. So there are also varying needle sizes. So when they're sized, that's by diameter, which is our gauge, and they're identified by numbers. So when we think about gauge, we want to look at the viscosity, or how thick, as well as the route of medication that we're going to give. There are needle lengths, which can vary from 1/4 of an inch to up to 3 inches in length. Often, sometimes filter needles are used because we're drawing the medication from a glass ampule, and we can't be sure that we didn't get any fragments of glass, and the filter will move that out. There are often needleless systems of delivery for such things as IV medication, where we don't use a needle at all when we're into the patient, and this helps prevent needle sticks and exposure to bloodborne pathogens. However, needleless devices are disposed of in the sharps container as to those who would have a needle on the end. If you look at the diagrams to the left, you can see kind of some visual differences of the different gauges, and also below you kind of see a breakdown of what a needle looks like. It has a hub, it has a gauge number, the shaft is the length of the needle, and there's a bevel. And we need a bevel in order to break the skin surface. This picture is just what we call a carboject. And some medications come in these particular types of distribution, and it's a way in which we can inject that medication. These are just the steps in loading a carboject. Just kind of just take a peek at it, and we'll actually do some hands-on putting things in a carboject in lab on Thursday, as well as you can practice it on free time. These are examples of vials and ampules. Are glass ampules, which we have to snap that glass part off, and then we will withdraw the medication out. When you're using an ampule, you don't inject air into the ampule, and you want to make sure that all the volume has gone out of the neck of the ampule and is in the circular part. The other ones are vials. Some vials are single dose vials, others are multi-dose. If you're using a multi-dose vial, you want to make sure that it was dated at the time it was opened. Some are only good for 5 or 7 days per policy. Some might be good as well as 30 days. But if you come along a vial and you want to use it and it has not been dated when it was opened, unfortunately you shouldn't use that vial. It's not good practice to use that vial. You should throw that vial away, however the disposal waste system is, and open a new one and date it. So injection of medication, so depending on which way you're going to give it is going to depend on the penetration, the needle angle, and the site. And as you can see to the right, when you're doing intradermal, we're at a 50 degree with the needle. If we're doing subcutaneous, you may go 90, you may go at a 45, and we'll talk about the differences and when you might use those. And intramuscular is a 90 degree angle. So a couple of things you need to know is how much fluid are you giving, what is the characteristics or the viscosity of the medication, and where are you actually going to give the medication, and what other anatomical structures may be in your way at that site. So how can we help minimize discomfort? We want to make sure our needles are sharp. So one needle, one injection. We want to use the smallest length as well as gauge for the medication and the route. And what I want you to pay close attention to that is that we have to look at the route. So we wouldn't use a needle we would use for SubQ injection to give an IM. It would make it harder to pierce the skin and get to the muscle, and it would take longer and more force to inject that medication. So we need to think about all of that, and we wouldn't use an intramuscular type needle to give something intradermal. Sometimes you can apply anesthetic medication topically. We want to be sure that we insert the needle quickly and smoothly. We want to be sure we hold the syringe steady when we do our aspiration as well as our injection of the medication. And we want to inject the medication at a smooth, steady pace, slowly, and we are going to remove the needle quickly as well. So this is an example of how you give an intradermal injection. So we're giving it into the dermis. So you can use a local, it can be used for local anesthetics. Sometimes you'll see nurses do this prior to IV insertion. Tests for allergies are done with intradermal, and each of you have had an intradermal injection when you've received your TB test to determine whether you've been exposed. So common sites are the inner forearm, the upper arm, and sometimes the scapular area. And as you can see, it's a 15-degree angle. We want to avoid the subcutaneous and muscle or bone. We just want to get under that base surface, and when we inject the volume, we're going to create a little bubble of medication. Subcutaneous, we want to get to that subcutaneous tissue, and it's just below the dermis, but however above the muscle. So insulin and heparin are medications that you will, as a student nurse and as a nurse, most commonly inject subcutaneously. However, occasionally there are other medications that are ordered. It can be done two ways. You can pinch the skin and create like a little tent and go directly in at a 90-degree angle, and you will be right in the subcutaneous layer of the skin. If you don't, you can leave the skin flat, but you must go in at a 45-degree angle in order to get to the subcutaneous tissue. Should you go in at 90 with the skin flat, you will be more than likely into the muscle area of the skin. Okay, absorption is a little bit slower than intramuscular in the subcutaneous tissue. And these are just common sites for subcutaneous injection. There's intramuscular, or IM, and these are medications that are injected for rapid absorption as long as the patient has adequate circulation to the muscle area in which you have placed the injection. The three sites that we use for intramuscular injection are the ventral gluteal, the vastus lateralis, and the deltoid. If you have an injection that is less than 1 millimeter or less, you can use the deltoid. If it's more than a milliliter, you would want to choose one of the other two sites to inject the medication. You cannot inject more than 3 milliliters to one site. So if your volume to be given for an intramuscular injection is greater than 3 milliliters, you must use two sites. So you'll give two separate intramuscular injections. So this is the Z-track method. It's an injection in which we pull the skin layer back, inject directly straight down into the muscle there. We release the skin and it goes over. It can sometimes prevent the medication from coming back out the puncture site. It can sometimes decrease on a very painful injection the pain to the patient. And a lot of nurses like to use the Z-track method of injection. So then we have intravenous or IV. This is where we're putting it directly into the vein. The IV route is the most rapid response time to medications. And however, we need to be aware that of that when we give something IV, that we are going to get the most rapid response. And so we just need to be aware of that. We can also administer large volumes of fluid, can be administered this route. So let's say we dilute our medication in 5, we would have to give 2 IM injections, but IV, we could use all 5 of that. It could take a few minutes to hours to fully administer the correct dose. And what I mean by that is when you give, say, IV morphine, you're going to give that over 4 minutes of IV push, and then that's going to be the complete dose that you're going to give. Let's say you're going to give 1 gram of Rocephin, which is an antibiotic. That's going to probably be mixed in 50 to 100 milliliters of a fluid or a diluent, and you're going to give that IV piggyback, and you may give that over 30 minutes. You may give that over an hour. You could possibly give it over 2 hours. So it may not always be a quick, it may be over time. So how are IV medications delivered? IV push, or intermittent small volume, or controlled administration set, volume controlled. That might be a heparin drip. That might be a nitroglycerin drip. You're giving IV medication, but you're giving it in a volume controlled administration process. Medication is released directly into the bloodstream, so we need to be especially careful in preparing and administering the medication. We want to be sure that the IV site we're using, that we assess for any signs of infiltration or thrombophlebitis, because if the IV has infiltrated, then the medication is actually going to go into the tissue. And some medications that are given IV are very dangerous to the tissue, in which they can cause tissue necrosis. and that type of stuff if they actually extravasate into the tissue itself. And so what do you need to know if you're going to give an IV medication? You need to know if your IV medication is compatible with perhaps the IV fluids that the patient is getting, such as if I'm giving IV morphine, is it compatible with my patient's IV of D5 half with 20 milliequivalents of potassium? Can I give those together? If not, and we'll talk about this on Thursday, is that there's a process called SAS, or as it's defined, saline, administer saline, in order to clear the line of the incompatible fluid that's in there with normal saline. Then we're going to administer our medication that we need to give, our one-time medication, and then we're going to re-administer the saline to clear the medication we've given, so that when we restart the IV fluids, it won't come into contact with the medication we gave. So we do need to look at compatibilities. We need to look at the rate of administration. That's what is the amount of time it takes, or that we should be administering this medication IV. And we need to look at the volume to be given. How much are we giving? We also need to, one last thing is, we look at whether or not a medication needs to be diluted before we give it. Can we give it directly how it is in our vial, or do I need to dilute that medication in some normal saline to decrease the irritability on the vein itself? So sometimes we combine more than one medication in the same syringe, so we need to know if those medications are compatible. Okay, there's just a little paragraph about whether you're using an ampule and a vial, what the process is of which comes first, which comes last. And this pictorial just shows that I'm putting the air into A, I'm putting the air into B, then I'm going to draw B, then I'm going to draw A. It's just the process of how we inject our air and what process in which we then withdraw the medication. You will administer insulin. Insulin is a hormone used to treat diabetes. It is administered by injection because our GI tract will break it down and it will destroy it. We need to be sure we use the correct syringe, which is a unit-based syringe. We need to understand the classifications, whether we're giving a rapid, a short, an intermediate, or long-acting, because that will determine our peak, onset, and duration for the insulins that are ordered. When we've drawn up our insulin dose, we do need to verify the dose with another nurse. And many facilities now are requiring that second verified nurse is actually documented on the EMR. So we also need to know about how do we mix insulins, if we should have to mix insulins, and we'll discuss that on Thursday in our hour before we go to lab. You can't mix vials. I can't put regular insulin I can't mix inside the vial. I have to mix in my syringe. We don't mix insulin with any other medications or dilutants unless the prescriber has prescribed that. And we never mix insulin. We will never mix a long-acting insulin with any other type of insulin. And that's a never, never, never. So we need to talk about the 6 rights of medication administration. So there are 6 rights in which we use. We need to confirm each right 3 times in our process, and that is for patient safety. So we need to follow it with each patient interaction, and this prevents medication errors. We need to, before we administration, we're going to do it 3 times. So we're going to ask ourselves, do we have the right drug? Do we have the right dose? Is it the right time? Are we giving it the right route? Do we have the right patient? And are we doing the right documentation? Lewis Clark State College in our program sometimes adds a 7th right, which is the right education, which means that you understand any education you might need to provide for the patient, or if the patient asks a question about their medication, that you're able to answer that question and provide education as needed. But your book only lists 6, and you are responsible for knowing these, okay? So medication times. So is it a standing or routine? Which means that it's going to be administered at this specific time until the times are changed. So this would be whether something's giving Q day, every other day, QAM, TID, which means 3 times a day, or BID, twice a day. You may see medications that are given PRN, which is given when the patient requires it. This could be things for pain. This could be things for nausea. This could be things for chest pain. This could be things for having a bowel movement. They're only as needed. You could give a single or one-time medication, which means it's just ordered at one time for a specific reason. An example of this might be your patient's potassium level is below normal. And so the physician orders potassium replacement to be given one time. Stat is to be given immediately. It's urgent or emergent situations. And generally the time frame is within 20 to 30 minutes of the order or sooner. And now means it needs to be given right away, but the medication is not considered stat. So safe medication administration. You as a nurse are accountable to adherence to this. You are required to do safe medication administration. So before you administer any medication, you need to make sure that it's on the patient's medication administration record. You want to be sure that it is what the physician ordered. You want to review diet or fluids. So if my patient is currently NPO, which is nothing by mouth, and I have oral medications to give, I want to be sure and review whether or not the physician wants the morning oral medications given or he wants them held until the patient is back taking fluid. And do we need to look at an alternate route of administration and get those orders and get the medication administration record modified? I want to review relevant laboratory values. This, for example, would be as if I'm giving Lasix, which is a loop diuretic. It's going to cause my body to lose potassium. So if my potassium level is in a low or a panic level, I would want to hold the Lasix until the potassium level has gotten back up to a normal range. So I want to have a discussion with the charge nurse and the physician about the process of holding it until otherwise clarified. You may need to do a brief physical assessment. So if I'm going to give a beta blocker, which could lower my heart rate, I want to be sure I know what my heart rate is before I give that medication. Because if my heart rate is bradycardic or a low heart rate, say less than 60, and a physician may give a parameter less than 55, hold the medication, I want to have checked that particular physical assessment before I give it. So to decrease errors, safe practice and standards dictate that nurses follow only written orders. Or you may receive a verbal order, but you want to get it written down. Or a telephone order, but you want to get it written down before you administer a medication. So interpreting an order, it's a step that you should never overlook, because we assume legal responsibility for all medications. So we need to look at the order, and we need to be sure that it's correctly read and interpreted initially, and usually 2 people see this. So when we used to do it by paper, the secretary would write it on our medication administration record, and then as a nurse I would have to review that order and make sure she interpreted it correctly, and both would sign for responsibility. Currently, when we have our electronic, the order is directly sent to pharmacy. They will place it on the EMR, but either the charge nurse or the nurse needs to review the orders as well and make sure that pharmacy has correctly placed it on the medication administration record. So 2 sets of eyes see it. So we must understand the purpose, the dose, typical dosage, route, and side effects of medications before we administer them. And we should always clarify any order if we have any questions about it. Always. It's better to double check than to give something and have a negative outcome. So there are medication errors, and they happen all the time. It's one of the safety standards that we're trying to decrease medication errors. So medication errors include the wrong medication, the wrong route, the wrong time, any misstep in any of those 6 rights that are failed to be done. So they often are preventable, and they can lead to inappropriate medication use, and they can cause harm to the patient. So they can occur anywhere along the system, from the manufacturer to the patient and families and the healthcare area. There are several types of medication errors, and like I told you, they can happen at any step. So measures that can help reduce errors. We replaced handwritten orders with computerized orders, so we didn't have to try to decipher the physician's writing. And also, many hospitals use a barcoding system when administering. So before we talk about dosage calculation, so what is your responsibility for a medication error? If you find a medication error, you need to report it. If you make a medication error, you need to report it. Either way, it is, as the finding person, you need to report it and fill out the appropriate paperwork. And if you commit it, you need to fill out the appropriate paperwork. And we'll go over what that looks like to reconcile a medication error on Thursday during our hour of discussion. So just know that as a nurse, you're responsible for whether you find it or you commit it. So we do have to do dosage calculations, and that's going to help us find the right dose, because not all medications come in exactly the amount the physician wants the person to receive. And you have been doing lots of these, and so I'm not going to review this slide. And these as well. This just talks about some ways that you can do a dosage calculation. This is another way of doing dosage calculations. So we also have to do an assessment. So we're going to get baseline data and any medication specific assessment. We're also always doing an ongoing assessment. This evaluates the medication effectiveness and allows for early detection of either side effects, adverse effects, or reaction. We always want to review allergies, whether that's to food, drugs, or other substances, because we know that people who are allergic to shellfish could have a iodine or betadine allergy. And we also want to review the patient's laboratory measurements that are available to us. We want to do physical assessment, vital sign assessment. We also want to look at the patient's ability to swallow. We want to make sure they have adequate muscle mass if we're going to give an IM injection. We want to be sure that the venous access that the patient has is functioning. And we want to be sure that the skin site is inspected for intactness, redness, or anything else that might prevent us from applying a topical medication. Documentation. Do not document medications until it is actually given to the patient. You only document the medications you have given. You don't document for another nurse that a medication was given that she gave. You want to be sure that you document given, time, and held. Those are important things. So sometimes you might actually use paper charting, and if you do, be sure it is legible. Be sure that you use the appropriate ink color depending on the facility, and you never leave any blanks or spaces or white out on your documentation. So for computerized charting, you want to ensure that everything is where it needs to be. You want to be sure that the actual caregiver that you're logged on and someone's not using your log on. And that if you have to override something manually in order to document, that you document why you overrode the system. So some people use computerized and paper charting, and you want to be sure that you document any adverse effects that you note on the patient. Are there any nursing diagnoses that you might see related to medication administration? Here's a couple: knowledge deficit, constipation, which can develop related to opioid use, or non-compliance, which is related to the patient not understanding their medication. So I want you to understand that non-compliance is not just not taking the medication at all. It is really related to whether or not the patient takes the medication the way it's prescribed. So if it's prescribed twice a day and they're only taking it once a day, that's non-compliance. If they're prescribed 10 milligrams and they're taking 20, that's non-compliance. And that relates to education. So what do we need to do in terms of implementation and evaluation? We want to be sure that we administer our medication appropriately and utilizing the 6 rights of medication administration. We want to be sure that there's goals and outcomes that might be related to our medication administration. We want to be sure that we are following the protocols. We want to be sure that we're documenting appropriately on the administration record, and that when we're preparing and administering that we're doing it correctly, safely, and accurately. And thank you, and I look forward to seeing you guys